Welcome back, everyone. And thank you for being on time. If you are joining us for the first time and you are one of our webcast viewers, we have a full afternoon planned, which includes polling, interactive polling, and session evaluations today, along with many CMS subject matter experts. Also, if you are joining from the webcast for the first time, just a reminder that utilizing an Ethernet connection instead of Wi-Fi and using Google Chrome instead of Internet Explorer may help to increase your webcast streaming speed and prevent delays. We are featuring polling during our event today. Thus, if you have not reviewed the polling instructions, please review the participant instruction document that is posted on the CTEO website. That'll tell you how to get linked up to the polling. Also note that for our webcast viewers, if you have questions for any of the presenters, you can send them in to us. Submit those questions by following the Ask CMS live questions link that is also on the CTEO website. I am happy to introduce our next speaker, who will provide an understanding of the Emergency Preparedness Final Rule released in September of 2016. From the Division of Institutional Quality Standards, please help me welcome Ranisha Blackstone.
So good afternoon, everyone. Again, my name is Ranisha Blackstone, and I work in the Clinical Standards Group within the Centers for Clinical Standards and Quality here within CMS. And I am going to be presenting for you all today on the Emergency Preparedness Final Rule that we released last fall of last year. I first want to thank you all for joining me today, and I hope that you find this presentation informative. We are pleased to have finalized these regulations, which we believe will ensure that providers are adequately prepared to meet the needs of patients during a disaster, as well as establish a more coordinated response. So to begin, I really just wanted to survey the room and get a feel from the audience about who in the audience is actually familiar with the CMS Emergency Preparedness Final Rule. So our first polling question is, on a scale from 1 to 10, 1 being the lowest and 10 the highest, how prepared is your PACE organization to meet the new CMS Emergency Preparedness requirements? Okay, oh, more coming in. Okay, so it seems like it's pretty split between a little not prepared and pretty well prepared. So for those who do feel prepared, I hope that this presentation hopefully supports your current efforts in trying to reach compliance. And for those who feel less prepared, hopefully this presentation will provide you with some information to move you closer to becoming in compliance. So the two main objectives for this presentation this afternoon are to provide you all with a general overview of the regulation in hopes of gaining a better understanding of the requirements in the final rule, as well as provide you all with resources and technical assistance services that are available for assisting you with the development of your emergency preparedness programs. So again, I work in the Clinical Standards Group, and our primary responsibility in the agency is to establish, maintain, and revise as necessary the health and safety standards that healthcare Medicare and Medicaid participating healthcare providers must meet in order to participate in the Medicare program. And so the health and safety requirements are known as conditions as participation, conditions for coverage, and requirements for participation depending on the provider type, and they are established in accordance with statutory authority. The COPs help CMS ensure that providers participating in the Medicare program provide high-quality care and work towards continued quality improvement. And then in addition, I'd note that the health and safety standards serve to protect all individuals who receive services from a provider and not just Medicare beneficiaries. And then the specific health and safety standards related to PACE organizations can be found in Part 460, subparts E through H of the Code of Federal Regulations. So we published a emergency preparedness proposed rule in December of 2013 and subsequently finalized the regulation in September of 2016. And so the regulation establishes national emergency preparedness requirements for 17 different Medicare and Medicaid participating provider types, including PACE organizations, to plan adequately for both natural and man-made disasters and coordinate with various emergency preparedness systems. So specifically, this regulation expanded upon and replaced the pre-existing emergency preparedness requirements for PACE organizations found at 460.72 paragraph C. And the implementation deadline for the final rule is November 15th, 2017. There is a typo on the slide that says it's the 16th. The correct date is the 15th. And so by way of background, we began developing the emergency preparedness proposed rule in the wake of Hurricane Katrina, when there was a clear need and what we believe a demand for this type of regulation, as evidenced by numerous GAO and OIG reports that analyzed provider response in response to a emergency event or disaster, as well as various inquiries that we would receive here at CMS following a disaster. And so our preliminary research included reviewing our existing Medicare regulations across provider types, and we determined that they were inconsistent. So in some instances, you had providers who had somewhat of substantive emergency preparedness requirements, whereas other participating providers had none. And then, in fact, PACE organizations are one of the few providers who did have a somewhat substantive set of pre-existing emergency preparedness requirements, including requirements to implement procedures for both medical and non-medical emergencies, requirements to provide training to staff and participants, as well as requirements to test their disaster and emergency plans annually. And so based on this analysis, we believe there was a need to address the inconsistency across providers in the level of emergency preparedness, and we felt that the existing regulations were not sufficient enough to address communication and coordination, contingency planning, as well as training of personnel. And so from there, we looked at existing emergency preparedness standards to determine best practices, and we had several goals in mind that we sought to achieve through the regulation. So our first goal in developing this regulation was to address the systematic gaps that were identified in the GAO and OIG reports following that analyzed provider response after a disaster. And then second, we strive to establish consistency and work to develop a regulatory framework with core elements that can be utilized across provider types, while also tailoring the requirements to the individual provider types' specific needs and their individual circumstances. And then finally, we wanted to encourage coordination within communities and states, as well as across state lines. And we believe that emergency preparedness is at its greatest when providers think in terms broader than their own facility and encourage participation in healthcare coalitions. So the publication of the proposed rule in December of 2013 did include a public comment period, which we did extend the time frame for given the scope and complexity of the regulation. And in response, we received nearly 400 public comments. Commenters included individuals, healthcare professionals and corporations, national associations, health departments, and emergency management agencies, as well as comments from the many individual facilities that are directly impacted by this regulation. Generally, commenters were supportive of the intent behind the regulation. We did receive a few comments from PACE organizations and associations who were generally in support of the rule, and in particular, the need to address communication and coordination with other systems of care. Many commenters noted that while necessary, the changes would be costly and burdensome for many facilities. And then given the complexity of the regulation, many commenters requested that we delay implementation of the requirements for several years, citing concerns of administrative burdens, lack of funding, and then also the variation of experience among the different providers that are impacted by the regulation. However, we did receive a few comments in regard to concerns with continuing to delay a implementation or compliance date for these requirements. And so ultimately, in response, we did delay the implementation date for 1 year following the effective date of the regulation to allow providers more time to come into compliance with the new requirements. And then lastly, a few commenters shared concerns regarding overlap with existing emergency standards, and they were concerned about how our regulations would overlap with them or in some ways possibly conflict with such standards. And so the final rule does respond to all of the comments that we received, and I do encourage you all to take an opportunity to read both the proposed and final rules if you have not had an opportunity yet. So now I will begin to walk through the requirements of the final rule. Again, the implementation date for the regulation is November 15th. 2017, so the date is sneaking up on us. The regulation identifies 4 elements essential to an effective preparedness program. Each element of the program must be reviewed and updated as necessary annually. I will briefly mention them here, and then I will discuss them in more detail as we continue through the presentation. So the first element is risk assessment and planning. Under this requirement, all providers must develop an emergency plan using an all-hazards approach and identify in advance essential functions and who is responsible in a crisis. Second, facilities must develop policies and procedures that are based on the emergency plan and the risk assessment, and speak to issues such as medical documentation and evacuation or sheltering in place. Third, there's a requirement for a communication plan that allows for alternate means of communication, providing information to local authorities, and sharing medical documentation. And then lastly, the emergency program must contain a training and testing element. I note that the specific requirements of each of these elements are modified based on the characteristics of each provider type required to comply with the requirements of the final rule. Now, the first element requires providers to develop a emergency plan based on a risk assessment. The risk assessment must be documented and used in all hazards approach. The term risk assessment describes a process facilities use to assess and document potential hazards that are likely to impact their geographical region, their community, their facility and population, and identify gaps and challenges that should be considered and addressed in developing the emergency preparedness program. We do understand that the healthcare industry may also refer to a risk assessment as a hazard vulnerability assessment or analysis. The plan must include strategies to address events identified in the risk assessment, plans for evacuating or sheltering in place, and arrangements for working with other providers in the area. The plan must also address continuity of operations. So, for example, by addressing operations, we would expect a facility to address the number of individuals they serve, the level of care and services that they provide, and the availability of staff and supplies. And then lastly, the plan must include a process for cooperation and collaboration with emergency preparedness officials to promote an integrated response. So one common question that we hear from providers is, what do we mean by all hazards? An all hazards approach is an integrated approach to emergency preparedness planning that doesn't specifically address every possible threat, but ensures providers have the capacity to address a broad range of related emergencies. So these may include care-related emergencies, equipment and power failures, interruptions in communications, including cyber attacks, loss of a portion or all of a facility, and interruptions in the normal supply of essentials such as food and water. We would expect providers to consider their geographic location, business functions that should continue in the event of an emergency, risks that the provider is likely to confront, contingencies, and also to determine whether arrangements with other providers is necessary to ensure continuity of care. Each provider is required to develop policies and procedures based on the risk assessment and the emergency plan, and must address a number of topics, including the provision of subsistence needs, alternate energy sources, sewage and waste disposal, and procedures for evacuating or sheltering in place. And so with regard to subsistence needs, PACE organizations are required to provide for adequate subsistence for all participants and staff for the duration of an emergency or until all its occupants have been evacuated and its operations cease. Facilities have the flexibility in identifying their individual subsistence needs that will be required during an emergency, and there are no set requirements or standards for the amount of provisions to be provided in a facility. And then last, I'd note that policies and procedures must also address a system to preserve medical documentation that ensures confidentiality and compliance with HIPAA regulations. The next element we will discuss is the communication plan. This requires facilities to develop a plan that complies with both federal and state laws. The communication plan must include the names and contact information for staff, participants' physicians, entities providing services under arrangement, as well as state and local EP officials. It must include primary and alternate means of communicating with staff and emergency preparedness officials, such as cell phones or satellite systems. And then lastly, there must be a method to share medical documentation and participant information under a organization's care, including their general conditions as well as their location. The goal of the communication plan requirement is to ensure that care is coordinated within a provider facility, across healthcare providers, and with state and local public health departments and emergency management agencies. And so the fourth and final element requires providers to develop and maintain a training and testing program. So after the risk assessment is conducted, the emergency plan is developed, the policies and procedures are in place, and the communication plan has been considered. There must be training and testing provided and in place so that all personnel within a facility know how to respond to emergencies that were identified in an organization's risk assessment. So this element is intended to not only assess the feasibility of a provider's emergency plan through the training and testing, but also to encourage providers to become engaged in their community and to promote a more coordinated response within the facility. So specifically, providers are required to conduct 2 testing exercises annually. One community-based full-scale testing exercise, and then one additional exercise of their choice. And this was a change from our initial proposal that we put forward in the proposed rule in hopes of increasing flexibility for providers. By allowing providers to choose their testing exercise, we hope this affords flexibility to determine which exercise is most beneficial as you consider your individual and specific needs. Now, there are a couple of layers to the requirement for the full-scale exercise, as the term full-scale exercise may vary by location or provider type. I want to take the time to clarify that CMS considers a full-scale exercise as any operations-based exercise that assesses a facility's functional capabilities by simulating a response to an emergency that would impact the facility's operations and their given community. And so we did not define community to afford the flexibility to develop exercises that are realistic and reflect the risk and composition of an individual provider's community. However, the term could mean entities within a state or multi-state region. And so we do understand that participation in a community-based full-scale exercise may not be feasible for certain providers or facilities, or this type of exercise may not be readily accessible given someone's geographical location, or if you're located in a rural area. So the requirement does provide the flexibility to conduct a testing exercise that is based on the individual facility. So this individual facility-based exercise must be sufficient enough to maintain knowledge and skills and adequately test the emergency plan. Lastly, I'd note that in the event that a provider were to experience an actual emergency event that would activate their emergency plan, that facility would be exempt from the testing requirements for 1 year following the onset of the emergency event. And then just as a reminder, all of these 4 elements are required to be reviewed and updated as necessary annually. Now, I mentioned earlier that in general, the requirements are consistent across provider types, but there are some variations based on the specific characteristics of the individual provider. So one variation for PACE organizations is that they are required to inform state and local emergency preparedness officials of the need for assistance with evacuations. So these policies and procedures must address when and how this information is communicated to emergency officials, and then also include the clinical care that is needed for participants. So for instance, in the event that a participant would require evacuation, the responsible agency should provide emergency officials with the appropriate information to facilitate the participant's evacuation or transportation. So this may include whether or not the individual is mobile, what type of life-saving equipment does the individual require, or whether or not this equipment is able to be transported. And then another variation for PACE organizations is the requirement for tracking on-duty staff and sheltered participants both during and after an emergency. So given that PACE organizations provide a continuum of care for their participants, we anticipate that participants will return for care following an emergency. So tracking before and after an emergency allows for a continuation of regularly scheduled services. We do not specify a type of tracking system that must be used. Rather, a provider has the flexibility to determine how to track, whether it uses an electronic database, hard copy documentation, or some other method. I do believe that a number of states already have such tracking systems in place or under development, and the systems are available for use by healthcare providers. So I'd encourage you all to leverage the support available through local and national healthcare organizations for resources and tools for tracking participants. So I mentioned this important date a few times throughout the presentation. And so the second polling question is, what is the implementation date for these emergency preparedness requirements? Okay, so it looks like most of you guys are hanging in there with me. The implementation date is November 15th, 2017. Providers were given 1 year to come into compliance with these requirements. And then enforcement practices for PACE organizations are the same as the current enforcement practices in place right now. Okay, so with the implementation deadline approaching, CMS has released interpretive guidelines to assist with the implementation of the requirements. In addition, our survey and certification group here in CMS developed a dedicated website to assist providers with meeting these emergency preparedness requirements. This website includes FAQs, sample plans, and other useful information. CMS will continue updating this website as information continues to become available. And then questions about these requirements or enforcement can be submitted to the email address that is on this slide. And then in addition, we would welcome any information or assistance that you all may have that you feel might be useful to share with others as well. So we definitely want to hear from you if you have something to share. And so in addition, the Office of the Assistant Secretary for Preparedness and Response, widely known as ASPR, another agency within the Department of Health and Human Services, has been instrumental in providing resources, templates, and technical assistance to the provider community through their information exchange known as TRACY. TRACY is a healthcare emergency preparedness information gateway that provides access to information and resources to improve preparedness. CMS has partnered with ASPR to provide this technical assistance and share resources and best practices to help providers start, continue, or update their documents required by this final rule. TRACY includes a resource library and topic collections highlighting specific health and medical preparedness topics, as well as a technical resource domain that provides help with conducting risk assessments, developing the 4 elements of the requirements in this regulation, and conducting corrective action planning as well. So we strongly encourage providers to utilize TRACY as a resource for coming into compliance with this final rule. And so to wrap up, the next few slides contain links to additional resources and important information, including links to both the proposed and final rule, a link to the survey and certification emergency preparedness website that I mentioned earlier, as well as a link to the interpretive guidelines for the final rule, where you can find a lot of helpful information for in your efforts to come into compliance with the requirements. And then this slide provides links to the presentation slides, audio recording, and transcripts for 2 additional national provider calls that we held on the emergency preparedness final rule. There likely could be information in these calls that I didn't have an opportunity to discuss here, so I would recommend you guys also checking out the information in these presentations as well. And then finally, this slide includes a link to a helpful ASPR document that is supposed to provide various resources at your fingertips. Well, I thought I had a polling question, but it doesn't. Oh, okay.
Can we make sure we're on the right polling? Perfect, thank you.
Okay. So just to conclude, I wanted to reiterate the core requirements of the final rule again and I guess test your knowledge. So what are the core elements required as a part of your emergency preparedness program? And so it looks like we have 100%. So that's great. Again, the 4 core elements are emergency plan, policies and procedures, a community plan, a communication plan, and a testing and training program. So with that, I really just want to thank you all again for attending and for giving me your time this afternoon. And I will turn it back over to Kay.
Thank you, Ronisha, for the discussion on emergency preparedness. If you would like to evaluate this session, go ahead and take out your phones and text your response, or go to the Poll EV link on your tablets, iPad, or computer, and enter A in response to question 1, would you like to evaluate this session? And go ahead and send your response. Remember to click on the link and follow the instructions. Up next, a speaker from CMS will provide an overview and an update on 1/3 financial audits of PACE organizations. It is my pleasure to introduce from the Office of Financial Management, Armando Verrata.
Thank you, Kay. As Kay mentioned, my name is Armando Verrata, and I'll be giving a brief overview today of the 1/3 financial audits. Okay. And that goes into the objectives for my presentation today. Again, provide an overview of the 1/3 financial audit process, provide some examples of the audit findings that we've seen, and also to be able to answer any questions and concerns that you may have. And I know it's after lunch today, so I'll do my best to try to keep everyone awake and engaged. We'll start with a polling question. It comes up. Should I just read the question? Okay, I'm sorry. And the question is a Chevy Corvette, okay, an allowable Medicare expense on the Medicare Part D bid? And yes, that is a serious question, and yes, I do have to ask it. And while everyone's submitting their answers, I'll also rephrase the question. Is a Chevy Corvette or a Porsche an allowable Medicare expense? And if that's not clear enough, is a Chevy Corvette or a Porsche that your spouse uses an allowable Medicare expense? Right. Okay, obviously the answer is no, and yes, these are real examples. My colleagues actually worked on these audits, and luckily it was not a PACE organization, so we didn't see PACE members being transported in a Porsche or a Corvette. But these were small, closely held companies, and one of these companies was so small that when we did the site visit, the physical address was an empty office space somewhere. So needless to say, we are no longer doing business with these companies. On to the next slide. So why do we do the audits? Just not to identify, Corvettes and Porsches, but the audits are an important internal control feature over the Medicare Part C and Part D programs. Annual payments for the programs are over $200 billion a year, so that is a lot of money that we have to be accountable for. As many of you know, the 1/3 financial audits, we just got done last year, our first audits of PACE organizations. We selected and audited 33 PACE organizations for contract year 2013. We are currently auditing our second round of PACE audits, and that's for 43 PACE organizations, and that included contract years 2014 and 2015 concurrently. We are about to start our third year of audits. We have approximately 35 PACE organizations that we have initially selected. The notifications for the audit notifications will be going out hopefully within the next month or two, and I will go over the notification process later in the slides. And the year that we'll be auditing will be contract year 2016. So what exactly do we audit? We have 4 main objectives that we audit and give opinions on. And the first one is to determine the accuracy of the prescription drug event data and your DIR, your drug manufacturer rebates, or the official title for that is the direct and indirect remuneration. We also look at the bid to make sure the base year experience is accurate. We also look at internal controls over your payment disbursements for Medicare benefits. And we also look at whether the PACE plan has met the solvency requirements for PACE. Coincidentally, we have 4 main objectives or assertions, but we also have 4 audit results or opinions that you may receive. The first one is an unqualified or clean audit. The second one is a qualified audit, and it's a clean audit, but we have a finding or a couple findings that we would like to be addressed. And I can tell you you'll see in the next slide, the overwhelming majority of all of our audit results are unqualified or qualified. The third and fourth categories are adverse and scope disclaimers. And if possible, you would like to avoid these categories. Adverse opinion is just, it's basically a bad opinion. We did the audit and your records are pretty much inaccurate. A scope disclaimer, we did the audit and for some reason the auditors cannot give an opinion on your records. So normally in that situation, it's records were not available or something of that nature. So you really want to avoid categories 3 and 4 if possible. And I'll go over what happens once you receive those types of audit results later in our presentation. Okay, as I mentioned, as you can see, most of the audit results are unqualified or qualified. We've been auditing Medicare Part C and Part D for about 10 years now. And I wanted to emphasize here, when we first started auditing Part D, other Part D plans, most of the results were qualified, and we have some disclaimers, but the majority were qualified or worse the first couple years. After the first couple years, the majority started being more clean audits. As you can see, in 2010, more than half. In 2012, more than half of the audits were clean audits. 2013, I think I mentioned this last year for any of those that were here, it was our first year of auditing PACE. We expected an increase in qualified opinions, and consequently, those were the results. We do expect those results to be still similar the next 2 years, and then hopefully after that, after we went through one whole round of auditing PACE organizations, we hope that those unqualified opinions will start getting back up to over 50%. So how are plans selected for audit and notified? True to our name, it's a regulation that we have to audit 1/3 of all Medicare Part C and Part D sponsors each year. And so that just determines the number that we have to audit. Then we go through a risk assessment. We look at the number of memberships, we look at the number of payments, we look at prior audits. And then once we do that risk assessment, we then notify the plans that they've been selected for an audit. As I mentioned, for 2016 contract year, the notification should come out within the next month or two that you've been selected for an audit. After that notification, we contract out the audits to CPA firms. We will then send you another email through HPMS letting you know which CPA firm will be conducting your audit. Once you've received the email that the CPA firm is conducting the audit, they will contact you and they'll start basically going over the entire audit process with you. They'll send you document request list, they'll send you test samples, and they'll start coordinating, scheduling the audits with you when you want the entrance conference on site. It is important to note that the quicker you provide any audit documentation, basically the quicker the audit goes. And over the last 10 years or so, we've had a number of delays dealing with PBMs. So please, if you have a PBM or pharmacy benefit manager, please stay on top of them to help them, remind them to provide the audit documentation in a timely manner. Also, if you change PBMs throughout the year, that can also create some delays in dealing with the old PBM. So please be mindful of that. The auditors will also ask you to sign an assertion letter, basically asserting that the data you submit to CMS is accurate and correct to the best of your knowledge and belief. Okay. As I mentioned, the auditors will schedule an entrance conference. That's normally an on-site conference, and we will be on the phone as well with the auditors. Well, they'll be on site, but we'll be on the phone for the entrance conference. Approximately 60 days after the entrance conference, there'll be an exit conference. Okay. And during the exit conference, during that 60-day time frame, hopefully any open items, any audit issues will be discussed and hopefully resolved during that time frame. Also, regarding audit findings and disagreements, that's always a touchy topic. It reminds me of an audit scenario I had. I know we're in Maryland. Is anyone from Maryland or familiar with Maryland here? This was a prior audit from CMS. I was auditing the Maryland Department of Labor, Licensing, and Regulation. And the Department of Labor handles unemployment insurance. So it's just, I was mainly doing unemployment insurance audits, and it was routine audit, and just, the money comes in, the money goes out to the beneficiaries, make sure you have controls over it. And I started going over the findings with management, and it was all routine stuff, making sure that there's controls over the payments. So I wrap up my work day, I go home, I let the dogs out, I check the mail, and I'm going through the junk mail, and I see this letter from the Department of Labor, Licensing, and Regulation. So I'm wondering, why are they mailing my home address? Like, what's up with this? So I open up the letter, and I read it, and the Department of Labor, Licensing, and Regulation has selected me to be audited. Like, what? Like, I'm the auditor. You're not supposed to audit the auditor. So I read further, and I'm a CPA. So the Maryland Board of Public Accountancy is part of the Department of Labor, Licensing, and Regulation. So just coincidentally, as I'm auditing this organization, they randomly selected me for audit. And the crazy thing is that we didn't have any crazy findings like the Porsches or Corvettes. It was just routine stuff. But they assured me and my management that it was just a random audit. So please, if there's any disagreements or anything during the audit, just let us know, and we'll discuss it and work it out. That made me think about, we are auditing insurance companies, and we have private insurance companies, so we don't want any of the auditors' claims starting to get rejected and going through audits or Medicare beneficiaries. So just a little funny little side note. So thought I'd share that. All right. So during the exit conference, again, if there are any issues, please address those. If you can address those with the auditors, or you can address them with CMS. Approximately 30 days after that exit conference, the auditors will issue a draft report to CMS, and we'll review it, and you'll also be asked to provide any responses if you choose to. If there's any disagreements, it's best to put those in writing. And also, even if you just want to respond, you can respond, and we'll include that in the audit report as well. You'll also be asked to sign a management representation letter, just stating that you provided all the documents and you did everything honestly and truthfully. Okay. And then once we're ready to issue the final report, we will again send a HPMS email to you, notifying you that the report is available in HPMS for you to download. Okay. As I mentioned earlier, there are 4 types of audit results. The unqualified audits, basically these are the good, clean audits, and there's really no follow-up action or no formal follow-up action for you to do. However, if there's any immaterial observations noted, we hope that you address those by the time the next audit occurs. Qualified audits. Again, these are the clean audits, but they have a couple findings, or at least one finding, and you will be required to submit a corrective action plan for any qualified audits. And it's important to note that errors such as PDE errors or DIR errors, we do request that those are updated in accordance with those policies. And if you're unfortunate to have an adverse or a scope disclaimer, our compliance unit will contact you separately to go over those more severe issues to make sure that they're adequately addressed. I don't know how applicable this is, luckily for PACE, but beginning in 2015, as a result of the 1/3 financial audits, Medicare Part C and Part D can be subject to a civil money penalties for issues that are identified that negatively or potentially negatively impacts the beneficiaries. Again, luckily for PACE, these are financial audits, and most of the PACE members are dual eligible, so it's very limited chances that there will be a financial impact to members as a result of our audits, but I am disclosing it just in case there is a possibility. Typical audit findings. As I mentioned, we have PDE errors, duplicate claims, and also related to that, what pops up when we look for duplicates are refill too soons. We also noted some Part A and Part B drugs being charged to Medicare Part D. And we also want to stress for pharmacy dispensing fees. Sometimes we see that there may be some confusion as to whether it's an in-house pharmacy or an out pharmacy where when you can charge dispensing fees to Medicare. Some other issues would be unallowable non-benefit expenses on your bid, the true out-of-pocket costs and the coordination of benefits, monitoring the PBMs. This round of audits, we have been seeing more PACE organizations using PBMs. So it is also important to just not say, here you go, process our PDEs for us, but also maintain some oversight of those PBMs. And that includes the drug manufacturer rebates. And that concludes my presentation. If anyone has any questions, we have an email account, mapdaudits@cms.hhs.gov, or you can email me directly, or our Deputy Director, Frank Chartier. Thank you very much for your time.
Hey, thank you, Armando, for the discussion on financial audits. Unfortunately, we don't have time for questions right now, but please hold those questions if you have them till the open Q&A session at the end of the day, and we can address them at that time. If you would like to evaluate this session, please take out your phones and respond to, or go to the web browser and respond to the question, I would like to evaluate session 3. Enter A and follow the instructions. Our next session features speakers from CMS who will provide an understanding of the PACE plan requirements for Medicare Part D, coordination of benefits, as well as an overview of Medicare coordinations of benefits and recovery operations. It is my pleasure to introduce to you Shelley Winston and John Albert.
Thank you, Stacy, and good afternoon, everyone. And when we were asked to speak about coordination of benefits, about COB, I was not at all surprised. Since the last time that there was a one-third audit and there were findings related to COB, we've had pretty much nonstop questions about it. So we felt that we should have a seminar about it, and we did last November, and questions keep on coming in. So the Part D mailbox that's appropriate for questions is Part D _COB@CMS. So what we plan to do today is go over some of the issues that we think are still unresolved. And there were also quite a few questions about the BCRC and curiosity about that. So John will speak about that once we go over some of the policy issues with coordination of benefits. So just to level set, what I would like to cover is some of the COB requirements for Part D plans, including PACE, and then go over some of the frequently asked questions and concerns, and also some observations that I've made about PACE plans and their COB efforts. So to remove any questions, yes, all Part D plans are required to coordinate benefits with other providers of prescription drug plans. So that is really unquestioned, and it comes from the statute, so it's something that we really must follow pretty much to the letter. There are also some other requirements. Since we're running a little bit behind, I will not read the slides, you have them, but basically you must convey the drug costs and troop values to the other sponsors. And I think what I've gathered from people who have asked questions are that they understand it's a legal CMS requirement or an HHS requirement, but they really don't see the value in it. So what I wanted to do was to do something that I'm not sure all the PACE plans understand, which is really how does the Part D benefit in non-PACE plans work, and how PACE COB fits into those. So this is the standard Part D benefit, and this applies to, this is just by point of reference, I've put up the standard benefit and the values for 2018. Clearly, not all Part D plans offer just a standard benefit, but for purposes of illustration, for the COB and PACE, we can start with that. And you can see the basic structure is 4 phases, with the deductible, the initial coverage limit, the gap, and catastrophic. So keeping in mind that Part D plans get paid differently for beneficiaries who are in the different phases. So if you have a Medicare-only beneficiary, they would leave the PACE and need to pay the deductible and go all the way through the benefit. However, if the PACE plan for a Medicare-only beneficiary hasn't conveyed those values, then they would really be stuck maybe in the ICL or in the gap, where really their drug costs would warrant them moving forward. But I know what you're thinking, which is, okay, but 95 to 99% of our beneficiaries are dual eligible, so how does it apply to them? So one of the things that for COB, what counts as troop is the entire amount paid by the government. So let's take an example. So you see that the deductible is will be $405 for 2018. So it's $405, but you would know that somebody who is a full benefit dual wouldn't pay anything. However, the way that this is structured, the benefit is structured, the amount that is paid by the government for a low-income subsidy, a LICS member, would count as troop. So therefore, if you're not carrying over for your low-income subsidy beneficiaries, you're not giving the gross covered drug costs and the troop expenditures, then the beneficiary will be behind. So in this case, that would throw off Medicare's payments to the plans. You can see in particular, there's reinsurance applied in the catastrophic phase, so you could see where perhaps the troop values are not conveyed and the plan is mispaid. We have to go through it, and the beneficiary would likely complain, and we would go through ultimate payments and appeals. So we just really want to get it right the first time for Medicare payment purposes. So we also, what about the beneficiary? So what's the impact of that? So for the beneficiary, for a low-income subsidy member, their cost sharing really that differs for in three phases rather than 4. So depending upon the level of low-income subsidy, their deductible can be anywhere from $0 to $83. And in the gap, you can see the various copay levels, and the lowest copay is in catastrophic. So suppose you've really paid, for the beneficiary, you paid gross costs that would land them in the gap, that would give them a different copay level than if they were in catastrophic. So when you don't accrue the correct values and convey them to the next plan, if the beneficiary disenrolls, which is really what we're talking about, then the beneficiary will end up paying more, unless, of course, they appeal it. So I guess my point here is TROOP and is really pretty important for both Medicare payment as well as for accurate beneficiary copays. So here are the Part D requirements for retroactivity, and a number of you have asked about that, so I just thought I'd pull it out on a slide. And there's also some time frames that are in regulation that might be of interest to you, which means that suppose you get audited and there's a finding that requires you to reverse PDEs or change. So you have 45 days once you receive notification of that. That's in reg. And there is a time limit. So suppose you have a beneficiary and you find out after the fact that they have an SPAP or an ADAP or another insurance. So, and you say, that was last year. Well, not so fast. It's the COB requirement is 36 months from the date of dispensing. So just wanted to point that as well. And then this is kind of, this is a cheat sheet, something to keep over your desk, what accrues to TROOP and what doesn't. Just for your information, we went over it at the seminar, and I just think it's useful information. Put it on your refrigerator, wherever you will see it. And then, so what are the basic requirements? There's been a little bit of confusion because PACE plans are not obligated to do automatic TROOP balance transfers, ATBT. We encourage it, but we know it's not right for all PACE organizations. But if you don't, then you still do need to convey those values when a beneficiary leaves your plan during a year. And so there's some more requirements, again, in deference to time. I'm not going to read the slides, but you have those. We also had some questions, particularly post-financial audit, about the EOB requirement. And so I think that EOB of course, PACE organizations are exempt from the EOB requirement. All other health plans have to distribute the EOB monthly if there's expenditures. You guys do not. But that doesn't eliminate a requirement to coordinate utilization with the beneficiaries, particularly when they're going to leave the plan. So and I think the reason why people use the term EOB is that it's much shorter than participant notice of benefit information for your new Medicare prescription drug plan. And I think if we could have a shorter acronym, we would probably use that, but you need to send that information to the beneficiary and also inform the new plan, within 7 days. So Medicare secondary payer, I'm not going to go into because that's really John's area, and he's going to cover that in greater detail. So this was a common concern that people had. They really didn't know who came first. And of course, coordination of benefits has two elements to it, which is who pays first, as well as conveying the information between payers. So we really I tried to do this in sort of a shorter form to help people. And the Part D program was started to really add coverage. The intent wasn't to relieve financial burden from those who already were paying. So from an employer view, if the beneficiary has an employer health plan, they would pay first. Same thing with no-fault automobile insurance, black lung. PAPs are those programs operated by pharmaceutical manufacturers, so they would pay first. And these are payers supplemental to Part D. Again, John is going to get into those. And these are mutually exclusive. So if something is paid for under Part A on another benefit, they cannot be paid under Part D. And again, Medicaid cannot wrap around, Part D cannot wrap around Part D, and then VA drugs, except if they're part of the waiver plan. So here is my first polling question, if you guys wouldn't mind. So the question is, PACE organizations are exempt from COB requirements, true or false? Awesome. Awesome, 100%. Great. Can't do better than that. Oops. After we told the answer, too. 91, okay. We're assuming it's a data error, and it's 100%. And now I'd like to introduce my friend, John Albert.
Thank you, Shelley. Hi, my name is John Albert. I'm the Senior Technical Advisor in the Division of Medicare Secondary Payer Operations, and we are the ones who run all of the coordination of benefits contracts that collect data for COB purposes, as well as initiate recovery actions where possible. Some of the stuff, Shelley kind of skipped over some of her stuff, so maybe mine won't be as redundant, but I wanted to reiterate some things before I get into the BCRC itself, and that is about MSP. And as she mentioned, as before, oops, I forgot about the little clicker. There we go. Again, MSP is the term used when the Medicare program does not have primary payment responsibility. That is when another entity is primary to Medicare. And basically, the statutes have been in place for a long time. And on my next slide, which I'll get to in a second, basically when Part D was passed, the laws were extended to the new Part D program as well, so that MSP applies equally to Parts A, B, C, and D. The statute states that, and the regulations require that all entities that bill Medicare for items or services rendered to Medicare beneficiaries must determine whether Medicare is the primary payer for those items or services. But it even goes beyond that. It's not just billing. It's basically anybody who's involved in paying claims or billing claims related to Medicare beneficiaries all have an equal responsibility to ensure that the right payers pay correctly. And this just for the policy wonks, some of the sites in the law. So the first part about MSP I want to talk about briefly are MSP and group health plans, which is different than the other side, which are known as non-group health plans, which are your liability workers' comp and no-fault insurers. There are very specific rules set up depending on the reason for entitlement to determine whether or not Medicare is the primary payer or not. So for example, if someone is entitled due to age, there are rules related to whether the coverage originates through your current work or your spouse's current work, and there are also employer size factors as well, which means that what the law says is that if you're covered through the policyholder's current employment status and the employer has 20 or more employees, Medicare is secondary payer to that group health plan insurance. There's similar rules for disability, but in disability, the difference is not just self and spouse, it's self and family members. So anybody in the family who's covered and has Medicare due to disability and is covered by an employer group health plan, again, Medicare is the secondary payer. The difference is also, though, that the employer size threshold is higher. It's 100 or more employees. Then you get into situations where you have multiple group health plans, and you have to consider the largest employer within that group is what applies to any employer within that group. So if it was a group health plan that had one employer had 500 employees and one had 2 employees, the 100 or more rule would apply to both employers in that group. Finally, the last one, which also has its own little quirks, is end-stage renal disease or kidney failure. In these cases, employment doesn't really matter. There's a 30-month coordination period, as you probably already know. And again, it's coverage through yourself or any of your family members as well, much like disability. I would point out to people that if they need a publication, there's a guide to who pays first out there for employers. If you just Google MSP, who pays first, it'll be the first hit. And it's a really good booklet to give you a lowdown of the different MSP rules. And finally, you also have situations in MSP where you have dual entitlement situations, and there are rules based on that as well. And generally, generally what drives it is what was the first reason you had entitlements. So, for example, if you had already aged into Medicare and developed ESRD, it wouldn't matter. The coordination period wouldn't necessarily apply in that case because the person aged into it first. So it's kind of what comes first, the chicken or the egg. Now with non-group health plans, which includes liability insurance, which includes self-insurance, workers' comp, and no fault, Medicare is secondary payer, period. The difference is that with non-group health plans, that often these cases, especially for liability cases, these are inherently in dispute. So somebody slips and falls in Walmart and they have $10,000 in medical bills and they have Medicare. Well, until that beneficiary actually decides, I'm going to sue Walmart, and they actually receive a settlement, judgment, award, or other payment, there really is no MSP in effect in terms of CMS's recovery rights. So Medicare will make a conditional payment until that happens, if it ever does. I mean, you can have liability leads that are 5 years old and maybe they settle, maybe they don't. But again, until there's actually a settlement, judgment, award, or other payment that essentially has the effect of releasing medicals, which is a really critical term, then there really technically is no MSP until that other party accepts that responsibility. And again, once that occurs, Medicare, meaning our contractors in the COB&R world, will assert that recovery, at least in terms of for Part A and Part B. So, like any organization, and that was the one question, MSP does apply to PACE. I mean, they're like any organization involved in beneficiary health care. They have the same, responsibilities as any other entity. So moving in from PACE and its responsibility, then we're starting to get into more like the functionality of MSP and coordination of benefits. So the program's in place to ensure that Medicare is aware of other payers that are out there so that it hopefully makes correct payments the first time, and if it needs to, recover mistaken payments. As I see on the bottom of the slide, I mentioned earlier that all entities connected to Medicare COB, which includes employers, beneficiaries, insurers, providers, everybody involved does have a legal requirement to properly coordinate benefits under MSP, and with any mistaken payments, many of those are joint and severally liable also for mistaken payments. So Medicare has a lot of authority to recover mistaken payments from anybody involved, and generally we recover in the case of group health plans, we recover from employers and insurers. In the case of non-group health plans, where the beneficiary has received a settlement, we recover directly from the beneficiary. So again, this is kind of a summary of what the responsibilities are, which are again to identify payers. This is all front-end work when someone is first receiving services. I mean, the hospital should ask, the plan should ask, everybody should ask, and try to get that information. So to properly facilitate COB and help everybody, we have this coordination of benefits and recovery program in place. And all these activities related to the collection and management and posting of data is what we do in COB&R. And that's where we get into the primary contractor that most people interface with, which is the benefit coordination and recovery contractor. This kind of goes back to the original coordination of benefits contract that was in existence since about 2000, which was the very first Medicare Integrity Program contract. The point of all of this MSP activity in COB&R was to consolidate all of this front-end activity and recovery activity into centralized locations. For those that have been around a long time like me, I mean, when I first started in Medicare, we had 80 fee-for-service Medicare claims processing contractors. Now we have like 16 max. But again, they all did their own COB and they all did their own recovery. So you can see how confusing and challenging it could be. So by Congress giving us this authority to consolidate, we did so, and it resulted in tremendous savings to the program, as well as much more efficient coordination of benefits. So the primary functions of the BCRC, which I listed on the slide, are the identification of MSP, and that is primarily through mandatory reporting and voluntary reporting by insurers and employers. We also take self-reports from beneficiaries, attorneys, or anybody who knows of a situation. Hey, I think this person has another insurer. But again, the primary MSP identification tool today is the mandatory insurer reporting process, which is also referred to as Section 111 reporting, and the law was finally passed that gave us the authority to require all insurers to report MSP data to CMS. Unfortunately, when that law was passed, it only applied to Parts A and B, not to Part D, which is too bad. So while we do have processes in place to collect all this, and we certainly get a lot of data, I just wanted to note for all those out there that there is no requirement to report supplemental Part D coverage or primary Part D coverage in the Section 111 reporting. Now, a lot of people that offer comprehensive GHP coverage will report it, and we do get supplemental data as well from lots of different partners as well. But again, that is still a voluntary process. So whatever you can do to encourage reporting, please do so. Get a law passed. Also, the BCRC does do recovery of the settlements and liability situations, as I mentioned. And I had a little factoid up there about how much they recovered last year just for that. Overall, the COB&R program saves the government close to $9 billion a year in preventing mistaken payments as well as other recoveries. They also administer the claims crossover process, which is basically a process that we administer to take in when there's another supplemental payer. When Medicare is the primary payer, we will take the claims in and basically do our processing and then cross that over electronically to the other supplemental payer. This again is for Part A and B. That saves them a lot of money and generates some fees for Medicare. And then finally, which is of most interest here, is that we do all the Part D data collection for primary as well as supplemental health insurance. And this is just a schematic of the current COB&R contracts. I guess this thing isn't working. Oh, there it is. So the Benefit Coordination Recovery Center, and then the Commercial Repayment Center is the other contractor that we use for recovering of group health plan debts, and then as well as for non-GHP where there's no dispute involved, typically like a workers' comp situation where the workers' comp just pays. That's who they would deal with there. And then we do have a workers' compensation review contractor, which deals with Medicare set-asides for workers' comp issues. The other two are support contractors. So in terms of, this is kind of an important topic, and that's, the role of the BCRC in building CMS data that's used by everybody to actually pay claims. And the BCRC I like to refer to as the gatekeeper to CMS's systems of records, which includes the Medicare Common Working File and the Medicare Beneficiary Database. They collect the data, they edit the data, and they do it for everyone, and all data flows through them. But again, they are the gatekeeper, not the owner of the data. The data has to actually make it and be posted to CMS's internal systems. Again, the Medicare Beneficiary Database and the Medicare Common Working File for it to be official. So I'll probably go off script a little bit and just talk about that briefly, in that, again, people will come to BCRC, they will report data to them, and then maybe 3 months later, they find out that nothing has changed. Well, there's usually a reason it didn't change, and that is because it failed all the validation processes that we use to take in that data to post it on MBD. If it's an electronic record, we edit it on the fly and send it to MBD. Usually, if it passes the COB edits, it'll pass the MBD and CWF edits. CWF actually has a more rigorous editing routine for MSP. But if it doesn't, especially in the case of like leads data that comes in, through a letter or something like that, I mean, we attempt to develop that data, but if it doesn't pass muster, we don't post it. So that's a very common occurrence. Why didn't my records? I told you guys that this guy has whatever coverage, or I told you guys that, this person, this or that or whatever. But basically, they have to go through a rigorous process because, again, we'd rather have no data than inaccurate data. We've always erred on paying claims first, and versus in terms of, we don't want to stop payment basically, and we don't want to have the risk of withholding benefits when someone goes to the hospital or the doctor and suddenly Medicare is not paying because there's an erroneous record on the CMS system. So that's one thing I just wanted to touch base with, which is a really important point when you're wondering what happened to the stuff that I submitted. We certainly have a lot more self-help tools available, web portals, things like that for different users so they can be better informed as to the status of their data, or in particular any recovery actions that CMS are taking. So in terms of the BCRC, in terms of what it does, I basically put a list of some of the high-level things, and that is they initiate the investigations. Again, people will report stuff to us, but they have to actually go out and confirm it. A lot of times, this is done through correspondence, forms, development forms, questionnaires, phone calls. We have a huge call center that takes in calls. I can't remember how many 100,000 calls a year, but it's a lot. I mean, it's a big call center of like 170 people or so. So the investigation again determines whether Medicare or the other insurance has the primary responsibility. And again, I mentioned they must meet certain criteria or the record will not be posted. This criteria goes for new information as well as any updates to information. The only exception that's pretty easy to push through is a termination. The most common update to a record is, hey, I don't have that insurance anymore. And that's one area where like the Medicare contractors can still submit simple terminations. We refer to that a guy retired and no longer has group health plan coverage. So again, we collect the information on employer group health plan coverage and liability insurance, et cetera. Again, I mentioned the Section 111 is probably 95+% of the data. Again, that process started to be implemented in 2008. It's 95% of the data. We've kind of built our processes around the Section 111 reporting because the law says the insurers must do this or there's a really big fine if they don't do it right. So we built our processes around the expectation that the insurers will comply. And again, that is the biggest source of information that we get. And that also means that in terms of, I think Shelley touched on hierarchy a little bit. The insurer data in our internal hierarchies that we use, not just for the Part D hierarchy, but for other stuff as well, we tend to put the insurer data up near the very top of the reliability factor when deciding if there's two pieces of conflicting information, which one we should use. But again, even in those cases, an insurer can be wrong, a Part C plan can be wrong. Again, the BCRC has the final say in what happens. In fact, they can even, under CMS direction, lock a record so that nobody can touch it. But again, the BCRC, again, is the gatekeeper. That's their responsibility. So they also transmit all this data they collect after editing it to the MBD for proper coordination of prescription drug benefits under, oops, sorry about that. Under MBD for proper coordination of benefits, and this includes building the Part D payer order that Shelley talked about earlier. Again, BCRC has the final say. So what does the BCRC does not do, and this is, again, some confusion that's been out there, is BCRC is not involved in Medicare eligibility, enrollment, or entitlement issues. And for the most cases, if there's any dispute about Medicare entitlement and enrollment, it really is between the beneficiary and the Social Security Administration to resolve that. There are some situations where CMS will kind of act as a go-between. We do have a group within CMS that works on some of those issues because, again, Social Security Administration does all the enrollment for Medicare. So again, the BCRC, if there's an issue with enrollment, they really can't respond and will point them to the beneficiary and Social Security Administration. They're also not involved in claims processing and claims payment determinations. Again, they are totally removed from that. They are merely building coverage records of other coverages or other records out there of other coverages and also establishing some payer orders. The claims payment processing has to take place, at the plans or at the fee-for-service contractors. There's all those appeal rights and whatnot involved in all cases that they can use. And again, the BCRC is not involved in those determinations. They're also not CMS's system of records, as I mentioned before. Again, this has always been a confusing thing. We can certainly take in information and update records, but until it shows up at the records, which means then the contractors have access to it through either, I guess, the Marks feed or access to Common Working File, it's not an official record until it shows up there. But again, that's the record that everybody should be using when making determinations in terms of what is out there. If you think it should be different, again, contact the BCRC. They can then take your information and hopefully make that update. Again, this kind of relates to, again, I mentioned the data shared with the contractors comes from CWF and MBD, not the COB or BCRC, I'm sorry. And I guess that goes back to use the term the COB feed to the Part C and D plans, and it really doesn't come from the old COB contractor, it comes from MBD and Marks. So when to contact the BCRC? This is kind of general for everybody, not just folks in the audience, and that is to report employment changes or any other insurance coverage information, to report a liability, auto, or no-fault claim or case, to ask general MSP questions, questions regarding correspondence and claim development letters, things like that. I don't think you guys really necessarily see all that. But the more important thing that you guys do have access to is the electronic correspondence referral system, or ECRS. This is the primary interface that all entities that do COB with the BCRC use to submit information regarding other possible payers out there. There is a whole manual out there, and actually on the, you can submit. That is the primary, most efficient way to submit information to BCRC. Again, they take that information. If it's something easy, they can usually quickly update CMS records, with that. But if it's something that requires further development, they might take that high-level information and go out and pursue development of new leads and things like that, which again, unless we get an answer back, and it's an answer that's a good answer, we can't do anything with it. But again, ECRS is a little bit easier way to track all that. I did include, just for your information, the two areas that kind of lead to everything, and that is the first one is the Medicare Coordination of Benefits and Recovery, like homepage. It's a whole section on cms.gov, and you can dig down into it regarding different audiences and things like that. There's also a lot of good background information as well in terms of the Medicare law and rules, et cetera. And then the other, of course, is the section from the PACE manual, the Chapter 14 manual, that includes all of the MSP requirements for PACE. And they're both, if you haven't seen them, they're both pretty clearly written. I know that the COB one has reams and reams and reams of information, but that's because it's a big program, and $9 billion is nothing to sneeze at. But other than that, that's all I had.
Okay, at this time, we do have a few moments that we can ask some questions. So if anyone in the audience has any questions, please step forward to the microphone, state your name, and where you're from. Looks like we don't have any questions, so I'd like to go ahead and thank Shelley and John for the discussion on the coordination of benefits. Okay, if you would like to evaluate this session, go ahead and take out your phones and text your response, or go to the Poll EV link using your tablets, smartphones, or computer. Enter A in the response to the question, "I would like to evaluate the session," and send your response. It is now time for a quick 15-minute break. Please return promptly at 2:30 for the next session. And remember, any webcast participants, if you have questions, please send them via the Ask CMS Questions Live link on the CTEO website. Thank you.
I mean, it was this long ago, I can't even remember. It was a MSP issue. The PACE plan, I think it was an unusual situation where, like, I guess the PACE plan had other insurance, and then, I don't remember. I have to look back up. But I reached out with some other, to PACE contact, and then, I can't remember. I mean, this was like 3 or 4 months ago. And we should look at it again. Yeah. Yeah. Like I looked through that piece manual. Like I couldn't find an answer anywhere. I think it's like a unique situation. Something someone's going to need to decide. Yeah. It's like example 18. I wish we had spent as much time on example 18 before we published that. Before answering afterwards. I mean, I wasn't PD guidance 13 or 14. Yeah, I was. Yeah. Well, yeah. And something's going to pop up that's going to make that wrong. It's been weird. I haven't seen him on anything lately for weeks. I remember someone said something they were really busy over there with some sort of notice, green notice, I guess, or something. Right, there was something else, some other notice. Maybe it was that thing that someone just I don't know, just crazy over there. Because even the meetings that I normally, a couple things where I expected him to be on. Summer, it's on vacation. I was just a couple of days. I just lost once Amanda was back that following week, I'm going to go to the NCPP thing for her. It's in Minneapolis. And those are long days. Like, it's like 10-hour days. I don't know, anytime I have to read, and it's not like I know, I don't have kids. I feel like it's just like, and then it's like 5 minutes in and I'm tired. And I'm ready for fall. Working out. It's run, but it's too. We were doing good. We were back in the. And you can do that one top. That one would be like that. Kind of. Seriously, right?
All right. Welcome back to everyone in attendance and those who are still joining us virtually. I would like to thank everyone for being on time. I have just a couple of reminders before we get started. Remember, if you're joining us virtually and you would like to ask a question, go ahead and use the Ask CMS Questions Live link, which can be found on the CTEO website. As a reminder, you will be able to provide your feedback regarding today's event via a survey link that will be emailed to you at the completion of the conference. Please consider taking a few moments of your time to provide CMS with your feedback. We are delighted to have our next speakers who will provide us who will provide participating PACE organizations with an overview of the payment policy and operations guidance. Please help me welcome Angela Stanley, Jasmine Myers-Duncan, and Teddy Patactical. And we will also have Christine Michon joining us for questions at the end of the session. Thank you.
Okay, again, my name is Angela Stanley. I work in the Division of Payment Reconciliation in the Medicare Plan Payment Group. So obviously, my job today is to give you an overview of how CMS makes Part D payment reconciliation, payments to plans. How do we collect the data? What do we use the data for when we get it in-house in ways that can be beneficial to you as PACE organizations? I'll go through what our expectations are in interacting with us as we do data analysis and share that information to you, what your responsibilities are as a plan in providing updates to PDE data and responses back to CMS. And then finally, I'll talk about, sort of the reason why we do all of this. Why do we edit PDE data? Why do we collect it in the first place? Why do we spend all of our time and resources and ask you to do the same? And that's to provide the most complete and correct PDE data, which is one of the primary sources of data inputs into Part D payment reconciliation. That's how much we know you actually spend on prescription drugs for Medicare beneficiaries. So again, we're going to just do a brief overview on what the PDE submission requirements are. Not necessarily the technical requirements, but timing, how frequently you should be submitting, when you learn of errors, what does that mean in terms of making corrections to your PDE data. Then we'll get into what does CMS do with the data and what you guys should do in response. And then finally, we will discuss the Part D payment reconciliation activities. I'll give you just a very high level timeline of when activities for reconciliation occur. They generally occur on the same schedule every year, so this is another thing that you may want to print and post on your desk, just so you aren't surprised when these deadlines come up every year. Okay, so as far as PDE submission requirements go, all Part D plans, including PACE organizations, are required to submit original PDE claims within 30 days of the date of service or when the claim was received, whichever is later. If you are notified that a PDE was rejected, or you are aware through your own data analysis that an error in PDE reporting has occurred, you have 90 days from when you learn of the error in order to submit adjustments and deletions into the system. These PDE submission timeliness standards have been in place for a number of years, since October 6, 2011, and we do monitor these activities, these submission timeliness standards on a quarterly basis. We have a process in place where if organizations are not meeting these standards, we do technical assistance outreach calls. If we notice a continued pattern where plans are failing to meet these timeliness standards, we do issue compliance actions. And unfortunately, we've noticed that PACE organizations are often the recipients of these compliance notices. We do realize that it's the PBMs that often submit this data on behalf of PACE organizations. So if you find that you are getting these compliance notices for timely submission, you may want to work with your PBM to sort of up the schedule of submissions. Instead of once a month, try once every 2 weeks. And we've seen over time, as organizations have upped their submission habits to once every 2 weeks, that their likelihood of hitting any of these timeliness standards has gone down dramatically. So that's a suggestion to take back if you find that you are getting these compliance notices. Once we get the PDE data in, we have several ways, several types of reports that CMS generates and shares with all Part D organizations, including PACE plans. The first set of reports that I'm going to go through, we actually post via a contractor that we use on the PDE Analysis and Reports website. The memo that's listed at the bottom of this slide gives information, if you're not familiar with the website, for where to go to request access and to make sure you or someone in your organization is able to access these reports, and you should make sure you have a process to take action on these reports. Some of the reports, there are 2 sets of reports: the immediately actionable PDE error report and the eligibility error reports that don't require any response back through the data analysis website. However, we do expect that plans follow the timeliness standards that we just discussed in order to submit corrections to the PDE data. There is one more type of report that's posted to the PDE analysis website that's not listed on this slide, and it is the Part D payment reconciliation data quality report. And this report basically takes PDE data across a beneficiary, rather than, how when we intake PDE data, we usually edit it at a line level. So we aggregate PDE data at a beneficiary level, and we can tell certain, we can identify certain errors that may be problematic with, troop accumulation or benefit administration, those types of things. And so with that report, we do expect that plans research those heavily and respond in two ways. Either if there are corrections to be made, that the PDEs are updated according to the time schedule we discussed. But if the plan believes that those PDEs are valid, then there is a response form that needs to be completed through the PDE analysis website. And again, we've observed that PACE organizations tend to be represent the plans that are non-responsive to these analyses that are posted. This is something that we track. It's something we take seriously because the PDE data, again, is the way that you tell us what your Part D costs are. We think these are valuable tools for organizations to have a process in place to make sure that what you have on record as your Part D drug spend is the same that CMS also has on record. So again, if you're not familiar with these reports, check out the memo that was listed a couple slides ago and get yourself signed up for those. The next set of reports that CMS generates for the benefit of plans are PDE monthly reports. And these reports are distributed through the drug data processing system. And again, we just ask that PACE organizations, like all other Part D sponsors, have a process in place for receiving these reports and doing some accounting between what the amounts that are displaying on these reports versus what you have in your own internal system. The first one of these reports comes from the prescription drug front-end system. It's called the PDFS response report. This is the first indication of if your PDE file was accepted by CMS. If you get a PDFS response report that says that file was rejected, then none of the PDEs contained in that file are saved to CMS's database. The next report that's issued by the system is the Cumulative Beneficiary Summary Report. It provides summary of accumulated totals at a beneficiary level for all of the dollar amount fields. One of these reports is issued per benefit year, and the report breaks out by contract and PBP. And again, use that to compare against your own internal systems. Another report is the Part D payment reconciliation report. And again, this is an even higher level. It's the year-to-date cumulative report for the contract of record for all of the financial amounts reported by your submitted contracts for use in the Part D payment reconciliation. And this is distributed monthly. Finally, we issue a plan-to-plan payable report every month. And it is, this serves as the invoice to the contract of record showing how much is payable to each of the submitting contracts. Okay, so what is the point then of spending so much time ensuring that PDE data is accepted by CMS, that it's complete and correct? And, of course, the point is accurate Part D payment reconciliation. You heard Amando talk about this is like the exact information that they're auditing when they come for 1/3 audits. And so, we want it to be correct because we want to make sure we're paying reconciliation based on complete and accurate data. Other organizations with a more compliance and internal controls bent also are looking at this information. And so the PDE data is one input into the Part D payment reconciliation process. We do gather other information about enrollment, and we get information about how much money was paid to the plans prospectively. The other source of information we gather that you heard Armando mention is the direct and indirect remuneration data. That data is collected via HPMS. And again, this primarily represents the manufacturer rebate data. And PACE organizations are unique in that some organizations do participate in manufacturer rebates while others opt not to. And so we have accommodations for PACE organizations that choose not to participate in manufacturer rebates, and so we'll talk about in the next few slides about how we accommodate those. So in the DIR submission process, which again happens via a module in HPMS, there are 3 parts that encompass a complete DIR submission. First, organizations have to submit a DIR submission information, and that's sort of like the gate that you have to go through before you can even upload any of your rebate data into the system. And I did just want to mention that we're currently now in the open window accepting DIR information for the 2016 Part D payment reconciliation year, as well as data for 2015 and prior through 2012 prior years to provide CMS annual updates to that information. The deadline for that is July 31st, so if your organization is surprised by this, now's a good time to touch base with the memo, and I'll give you some resources for organizations and people within CMS that you can contact for help. So again, we realize not all PACE organizations participate in manufacturer rebates and thus would not have DIR to report. However, if this is the case for your organization, there are still a few things that you have to do. Again, remember I said there were 3 steps: the submission information, the summary DIR data, and the detailed DIR data. So if you don't participate in rebates, you still must submit the DIR submission information, and there's certain information that you can indicate that you don't participate in rebates in that section, and then you must submit a summary DIR report indicating that your total DIR is 0. And you guys are not required to submit a detailed DIR report if you do not have any DIR to report on the summary. This slide basically goes over some specifics within the DIR submission information section that allows PACE organizations that do not receive rebates to indicate that. Again, this is another place where PACE organizations disproportionately represent organizations that are non-responders to the annual submission of DIR data. They require a lot of outreach on our behalf in order to collect this data from organizations. So in order to assist plans, PACE organizations, and traditional Part D plans, we have helpful hints documents available for each file that needs to be uploaded. And so my suggestion is that you attempt the upload early and often. And if you run into any issues, there are contact emails and phone numbers within these helpful hints documents. And I'll also provide a contact email at the end of my presentation. And please reach out to us if you're having issues with getting your files uploaded, and we'll be happy to help. I'd actually prefer to help now than after the deadline has passed. So please reach out. So if you believe that you've successfully uploaded your DIR information and you just want to confirm that what you thought you uploaded is in there, or if you uploaded, you found an error, you needed to re-upload a file, and you want to make sure we have the correct version. This slide gives you a walkthrough about how you can go about seeing exactly what DIR data report is saved and will be used for payment reconciliation. The final step in getting to a Part D payment reconciliation, payment or recovery to the plans is a series of annual attestations. And again, there are a total of 3 attestations that must be completed prior to Part D plans, including PACE organizations, receiving the money from CMS. And these include the attestation of data related to CMS payment to a Medicare Part D sponsor, attestation of data related to detailed DIR report, and a record and attestation of plan-to-plan reconciliation payments. And again, Part D reconciliation settlement will not be made if attestations are not received. So the attestation of data relating to the detailed DIR report does have a caveat with respect to PACE organizations that do not participate in manufacturer rebates and thus have no DIR to report. These organizations are exempt from submitting the detailed DIR report and, of course, then the attestation associated with the detailed DIR report. And just keep in mind, though, that even if PACE organizations do not have DIR to report, an attestation must be submitted for the summary DIR data, which you would have indicated as 0, so you need to attest to that, and for the plan-to-plan reconciliation payments. Again, this is the timeline I mentioned that just sort of walks through the information collection and how we use the information working up to issuing Part D payment reconciliations. And I will just tell you that on the second bullet of this slide, we say, the third bullet, the DIR submission window is typically in the month of June. This year, we did have a delay in issuing the final DIR submission guidance. So this is actually the end of July. July 31st is the deadline for submitting DIR data for this year. So I wanted to provide a few very good information resources for both PDE submission and timeliness and accuracy, as well as information for payment reconciliation. So HPMS, you've heard us talk about it before. If you're not in there, you should be in there daily. There's also the CSSC operations website and the PDE resource email mailbox, which I'll give you. So in HPMS, as you guys are aware, the policy and operational guidance memos are issued through HPMS. Often when we receive questions from the plans, we can tell if organizations haven't consulted the HPMS and haven't read the memos. And so we just beg that plans make sure you're consulting HPMS, use the search function to pull up all relevant memos, and just use that as a very first resource for answering questions. And again, within the DIR module, we do have the memos posted, plus additional helpful hints documents to help you get your files uploaded. HPMS also has many administrative and reporting functions. You heard some from Armando. We use it to collect DIR data. HPMS manages an email distribution list and points of contact that we may pull for email distribution. So for example, we have a specific DIR contact, so just make sure that you are constantly updating the points of contact that you have listed so the correct people in your organization get notified of the information that they need. If you are not an official point of contact for your organization, but you do wish to receive the emails that come out from HPMS, there's instructions on how to do that too. The CSSC operations website is listed here. You can select PDE from the sidebar menu, and that will provide you all of the updated file layouts, edits, system status reports. There's just a ton of information on training on how PDEs are calculated, how PDEs are to be reported. There are computer-based training modules on some complicated PDE calculation questions that we've gotten in the past from Part D sponsors. Additionally, CSSC also has their own website or listserv on their website, and we encourage everyone to sign up for that if you have not already. And finally, if you've exhausted both the CSSC website and HPMS and the wealth of information that's stored in the HPMS memos, there is a PDE Jan 2011 at cms.hhs.gov resource box. And so any and all questions that are PDE submission, data quality, timeliness, how it gets fed into Part D reconciliation, DIR, all of those types of questions. So basically everything, every topic that I've covered in my presentation, we have subject matter experts from my division that monitor that mailbox on a daily basis and would be happy to help work through your question and point you to the correct resource. Okay.
Thank you, Angela. Hello, everyone. My name is Teddy Patoctical, and I work in the Division of Formulary and Benefits Operations. Today, I'm going to talk to you about Part D formularies. First, I'll go over the background of Part D formularies, then how CMS reviews these formularies, and what's expected of sponsors when they develop their formulary, and lastly, how this applies to PACE organizations. So I'll start off with the background of Part D formularies. As described in the Medicare Prescription Drug Improvement and Modernization Act of 2003, CMS cannot mandate a national formulary. However, CMS has exercised its anti-discrimination authority to ensure that formularies are not discouraging enrollment of eligible Part D individuals. And in the beginning of the program, there was no template publicly or previously available by the private sector. So because of the review of the Part D sponsors' formularies, CMS had to develop this new process for reviewing these formularies. So to ensure that beneficiaries were not discouraged for enrollment, Part D formulary submissions must be reviewed and approved prior to bid approval. CMS receives hundreds of formularies for review each year. The initial formularies are submitted in the summer before the beginning of the contract year, and due to the volume of submissions and review timelines, a standardized process is essential for this. And because of the standardized process, CMS requires that formularies be submitted on a website called HPMS that was mentioned before. This website hosts different tools that allow CMS to communicate with the plan sponsors and allows for the standardization of the submission format as previously mentioned. Submissions are also based on the formulary reference file, or FRF for short, and I'll talk more about the FRF in the next slide. And reviews are usually conducted during the summer. The drug list, any associated utilization management requirements such as prior authorizations, step therapies, as well as plan submitted tiering are reviewed in 3 stages. After each review stage, Part D sponsors can provide a clinical justification, or they can revise their submissions, or do both. And the final stage of the review involves addressing any unresolved issues, formulary negotiations, and conditional approvals. So I want to go back to talking about the FRF. The FRF includes RxQEs. These are adopted from the National Library of Medicine, or NLM for short, their Rx norm classification system. This classification system has distinct brand names, generic names, strengths, routes of administration, and dosage form of drugs. The FRF serves as a pick list for drugs for the formulary inclusion, and it allows streamlined processes and reviews, as well as improved synchronization between CMS and Medicare Plan Finder files. But one thing to note is that the FRF is not a coverage list for Part D drugs. In other words, the medications on the FRF are not a strict list that plan sponsors must cover. I'll briefly talk about sponsors and how they develop their formularies. In addition to adhering to CMS guidance regarding formulary construction, it is CMS's expectation that Part D sponsors have a P&T committee, a pharmacy and therapeutic committee, that develops and reviews these formularies. The P&T committee must also review all the utilization management applied to drugs such as prior authorization step therapy and quantity limits. So how does this affect PACE organizations? In the Medicare Modernization Act of 2003, it states that PACE programs must provide all Medicare and Medicaid covered services, as well as state Medicaid programs may no longer cover Part D drugs on the behalf of dual eligible beneficiaries. So since PACE organizations must provide all services, this includes all Part D drugs, generally they're waived from having a formulary. PACE organizations may elect to offer a Part D plan similar to an MAPD local plan in order to account for the shift in payment, as mentioned in the previous slide. But once they choose to offer a Part D plan, they are subject to all the rules and regulations that are acted upon a Part D sponsor. If a PACE organization does not cover a certain medication, a certain Part D medication, or has any limitations such as prior authorization, step therapy, quantity limits, the organization is then deemed to be utilizing a formulary. And once a PACE organization is deemed to be using a formulary, that formulary must be submitted to CMS for review and approval in the same process that is followed by all Part D sponsors. And I want to end my section with a polling question to see if you see whether you guys think that this PACE organization should submit the formulary to CMS. And the question is, a PACE organization has rejected the coverage of a Part D drug because the patient has not tried and failed a preferred drug first. Is this PACE organization subject to the rules and regulation of a Part D formulary? Enter A for yes and B for no. And we'll wait for the results to come in, but we shouldn't wait too long. So results are coming in, and looks like the yes column is fluctuating. Looks like it's steady right now, so 92% of the people voted yes for that the PACE program should submit their formulary. And the answer is yes, they should. This PACE program, this PACE organization is deemed to be using a formulary that is similar to a step therapy requirement. And since they are utilizing a formulary, they are subject to all the rules and regulations that a Part D sponsor has. Their formulary should be submitted via HPMS and reviewed and approved before implementation. And I'll end with the last slide that I have. This is a Part D formulary mailbox. You can submit all formulary-related questions to this mailbox, and it will be answered by a subject matter expert. With that, I'll turn it over to Jasmine.
Thank you, Teddy, and thank you, Angela. I'm Jasmine Myers-Duncan, Indeed Data Group. I will be giving a brief overview of the types of compliance that some of you have encountered or could potentially encounter in your operations as a PACE organization. First, I would like to offer that PACE compliance can come from your account manager, or it comes from the central office, which is our division. And also note that any compliance you receive is separate from regular communications that we that you may have with your account manager. We encourage regular communication with your account managers. They're on the ground with you. Feel free also to always contact us here at Central Office, but just know that the communications that you may receive in the form of a compliance letter is separate from that regular communication. I do want to differentiate some things that you may have heard in session 1 in the audit process regarding compliance, because some of the vocabulary is the same, but there are some nuances involved. The compliance that I will be discussing is monitoring compliance. It's episodic data-driven analysis that the C&D data group conducts, which is different from the ongoing comprehensive program audits that you were reviewing in session 1. Compliance from our group typically is closer to real time, and by that we mean when we issue compliance, more likely than not, it has happened in recent times, whereas the program audits are done retroactively, so it may be a finding that was something that happened in a previous year, whatever that time period is prior to receiving that engagement letter from the audit committee. And also our compliance may also include some ad hoc issues that may come to our attention through complaints, through the account manager, through self-disclosure. So the first type of compliance you may receive is the notice of non-compliance. This is the most basic form of compliance that you may receive. It's often issued for a relatively minor regulatory non-compliance. It's to inform you that you are out of compliance, that we are taking note of this. It also puts you on notice that it has happened, and hopefully from there, the plan will take steps to remediate whatever that issue was. The second type of notice you may receive is the warning letter. It's an escalated version of the notice of non-compliance. It generally pertains to an issue to which you may have already received a notice of non-compliance, or it can be issued prior to receiving a notice of non-compliance, meaning depending on the severity of the issue at hand, the type of non-compliance, you may receive a warning letter and not actually receive a notice of non-compliance. There's also a warning letter with a request for a business plan. It's the same type of notice as the warning letter. However, CMS is asking for you to submit to us a workable, a real plan to implement within your PACE organization to remediate whatever caused the non-compliance. So this instance, if we're asking you for a business plan, there may have been great beneficiary impact with whatever the non-compliance was. So we want to make sure that it does not continue and that you have the ability to take the steps to correct that action. Finally, there's the corrective action plan. This is the highest notice that we would issue before referral for an enforcement action, a sanction, or a CMP. Typically, a CAP comes from multiple notices of noncompliance or warning letters having already been issued and the underlying issue has not been resolved. This too can be issued initially for a particularly egregious violation of CMS regulations and or the PACE program agreement. Throughout our entire compliance process, CMS remains in contact through the account managers as well as central office with the PACE organization to better understand what the root cause of the non-compliance is. So before you get to the higher levels of non-compliance, warning letter with a business plan or a CAP, we're going to be in contact with your organization to hear from you and to get an understanding of what is going on. As a general rule, compliance actions are not issued when there is a sanction or enforcement action for the same issue during the same time period. So we may take note that it has happened, but if there's a higher level of compliance in place at that same time for that same issue, we may not issue compliance right at that time. So to tie all of our presentation together, I wanted you all to get an understanding of why we chose these two topics and why they're related to our compliance. Payment, reconciliation, PDEs, and formulary issues are topics that are currently generating compliance or have the potential to generate compliance actions. Roughly 52% of all compliance issued to PACE organizations from January 1st of 2016 through yesterday July 19th, 2017, relate to these two topics alone. In that time frame, 48 compliance actions were issued to PACE organizations. Now, that may not sound like a lot given the breadth of the Part D program. However, PACE is a very small component with less than 200 organizations at last count. So 48 notices is actually sort of significant. There were 42 notices of noncompliance, 5 warning letters, and 1 CAP. 8 of the 48 notices were formulary related, and 17 of the 48 notices were payment related, either to DIR or PDEs. The 1 CAP, which is the highest notice that we will issue, was PDE related. So to Angela's point, to Teddy's point, the formulary issues, the payment issues, they are real issues. They are generating compliance. Like I said, our highest action that we will issue was payment related to PD, it was specific to PDEs. So if you all are having issues with these things, we have 2 mailboxes listed. Please submit your questions. If you don't feel comfortable asking them today, we're always available to you. We would like to get an understanding of what you may not understand, or if you're having difficulty submitting the information, or you're unclear what constitutes a formulary, so that we can help you, so that in the end, the PACE participants are not affected by this. And I will also offer my personal email address to you all. And it's my name, it's Jasmine.Myers-Duncan, and my name is spelled out in the beginning of the presentation, at cms.hhs.gov. Feel free to email me with your questions, and if I cannot answer it directly, I will certainly direct you to the person who will be best able to assist you. You okay?
All right. At this time, our session is out of time and we don't have time for questions, but you will have an opportunity to ask the session questions during our open Q&A session at the end of the day. And I would like to thank our presenters, Angela, Jasmine, Teddy, and Christine, for the information on Part D payment policy. Okay, it's that time again to evaluate the session. Go ahead and take out your phones or computers and text your response, or go to the poll EV link and enter your response A to the question, I would like to evaluate the session, and send your response. Okay, our last presenter for the day. She will discuss program agreements, including the purpose, roles, and timeliness, from the Division of Medicare Advantage Operations. Please welcome Denise Osborne Harrison.
Good afternoon. I'm happy to be here with you today. I've been working with Martha Hennessy and others. I work here in central office. Uh-oh. Here we go. I'm going to speak today a little bit about updating PACE program agreements. As you know, the program agreements really are the contractual document, the legal document that we use between CMS, the state administering agency, and the PACE organization. And so it's important that they stay updated. We want to make sure that they really contain the most current information. We do recognize that many of the agreements may not reflect current information, and so we've launched a very targeted effort to assess program agreements collectively with stakeholders and update them to reflect only the most current information. We're aware that it's likely that most PACE organization program agreements do need one or more modification. And so today's discussion will be brief, and we'll touch upon CMS's current efforts, objectives, and protocols regarding updating program agreements. So when is an agreement update triggered? If you have an application for a waiver or a service area expansion, then it's likely that your program agreement will be updated. The process will begin. We'll work collectively with all parties involved to assess and to update the agreement as needed. If during that particular time frame the program agreement is not updated we will have to look carefully at the issues, and that may result in a request for additional information. Another event that could trigger a program agreement update would be a request to amend the program agreement. This could be initiated by the PACE organization, by the SAA, or by CMS. If this happens, there really technically is not a deadline, and so what happens is we talk to you about the importance of updating your agreement, and we agree on a deadline. So the process involves what we call a cross-functional team, and that means that a couple of components at CMS are involved because they're subject matter experts in certain areas. And so it takes time to really collaborate, to get the information, to reconcile the information. And of course, the PACE organizations, as well as the SAA, is involved in assessing what the new information is and how quickly we need to get it done, and really what the final agreement should look like. So what's the process for updating the agreement? This is a very high-level description of how we sort of try to approach the process. For step one, the PACE organization and the SAA provides the account manager in the region sort of an assessment. They really, talk to the account manager about what they feel needs to be corrected or changed. Step two, as I just mentioned, the cross-functional team, those are the subject matter experts at CMS. They're going to look at information, they'll modify in some instances. In some instances, we have standardized language that those subject matter experts might then plug in to the draft document as it starts to evolve and morph to a final document. Step three, in central office, we conduct a consistency review, and that leads to a final draft. And so the consistency review, for example, focuses very much on Appendix T that has to do with waivers. There's some special steps that we need to take to look very closely at the content and to look at our sort of history of approval documents, look at the current regulations, and assess the content of Appendix T, which again focuses on waivers, to make sure it's worded properly and that it's meeting the needs of the organization. Step four, the cross-functional team signs off. So after all the input has been gathered, it's been reconciled, and a final version of the program agreement has been written, it has to go back again to the stakeholders, or the internal cross-functional team, if you will, so that everybody agrees that it has the right content. The 30-day waiver is agreed upon with the PACE organization, so I'm sure you're all familiar with that. That verbiage is in your approval letters. You do have sort of 30 days to take one last look at that final agreement, let us know if anything looks awry, and then we would change it. Or you can waive that because you might want to just start operating right away under the terms of the new agreement. So we leave that sort of up to you. And then the new program agreement, which again is a legally binding document, is issued by CMS. So this goes back to sort of the very step one of the process where the account manager is working with the PACE organization and the SAA. Typically, they'll send this form out to the PACE organization so that you can just start looking at all the appendices with the agreement, start filling in this form, and give us an idea of what some of the issues are. And that way we can determine where we need to focus, who needs to be involved, and the urgency around your particular situation. So validation prior to issuance of update. This is just a slide that really reiterates what I just said about the necessity for the entire cross-functional team to take one last look at the program agreement so that we can all agree that it's been updated properly. Per Article 6 of the program agreement, there is a 30-day waiting period. This is the waiver that I just mentioned. And again, it's something up for discussion between the stakeholders. So how long does it take to update a program agreement? What is the timing? It depends. If your program's operating under terms different than those set forth in the most recent program agreement, you really should alert your CMS regional office account manager. For example, if your Medicaid rate is wrong, or there's something in your waiver appendix that doesn't read right, or if something operationally has changed, and again, your program agreement is not accurate and you feel like it's incredibly important, you should raise that red flag and start that dialogue with the account manager. The two of you will then consider whether or not to update the program agreement, whether it should be done right away, and this is how we're prioritizing our work. As you can imagine, we have to sort of do a case-by-case basis and be methodical about the way that we approach the work to make sure that we, again, prioritize. So if you're unsure or you have any questions, please feel free to contact your CMS regional account manager to discuss your own unique situation. So if you have any questions, feel free to submit them to the DMAO portal. I know you're probably all very familiar with the portal, or you can email me at this address here. So thank you very much.
All right, thank you, Denise, for the discussion on program agreements. So if you'd like to evaluate this session, go ahead and enter A and follow the instructions. All right, our last session today is the open Q&A session, and what this means is we will bring our speakers back up on stage and give you an opportunity to ask any unanswered questions or questions that you have thought of throughout the day, and then these questions will then later get posted on the CTEO website for you also. All right, so we will go ahead and get started. And we have our first group, the session review of audit redesign. And I'm going to ask for, if anyone has any questions for Caroline, Daniel, Anne-Marie, or Lisa in the audience, to go ahead and step to the microphone. And I'm also going to ask for Caroline and Daniel to come up on stage to address your questions. Go ahead. Oh, could we have the mic in the center floor on? Try again. Try again.
It helps to turn it on. So, since this morning, I've been asked to ask you another clarifying question regarding the personnel files and contracted staff or providers. And I think the example that I want to ask you about is a contracted physician. For example, if a psychiatrist is contracted with the organization to come on site and provide clinic hours, if you like, do we have to have a personnel file on that contracted provider, and what would need to be in that file?
So that actually overlaps with one of the questions that we had received online, and I do want to say that we are taking back all of the concerns raised in our first session about contractors, and we're going to review those with our SMEs and offer some additional guidance on contractors and what we're expecting in that regard. But we can go ahead and review the other question that we received at the same time with regards to contracted physicians. And when contractors are in-house and they're physicians and they're having direct participant care, we are really looking at the regulations around personnel in 460-64 and 460-71, which don't distinguish employees versus contractors. They actually say employees and contractors, and then they outline the requirements that need to be met. So when we go in for audit, we would expect documentation in some form to show that those contracted staff on site have met the same requirements. And we don't dictate what that documentation looks like, but it has to be sufficient enough to show compliance with our regulations.
Okay, thank you.
Are there any other questions from our in-house audience? Okay.
I have a question, and this is not to belabor the point about contractors, but you specifically just made a distinction between services provided by physician contractors on site. So following your statement, that would mean that physicians that provide services off-site, you're not expecting personnel records for those.
Not necessarily, no. I said on-site because I wanted to stay true to the question asked as well as the question asked online, which was specific to on-site contractors. But again, we understand there's some questions around what contracted staff we're looking for and whether it would be facilities and or individuals. We're going to take those questions back and we'll be issuing guidance.
Okay, any other in-house questions? Okay, the next step then is to address questions that we've received from our virtual audience, and we're going to do this a little differently. I'm not actually going to read the questions. Daniel and Caroline are going to read the questions because some of them are very lengthy and they're going to kind of paraphrase them, so we thought this would be the best way to address it. So I will turn it over to them and they will address the questions that had come in from our virtual audience.
All right, thanks. So the first question that we had was, could you please clarify what CMS is looking for when reviewing the care plan with regard to all medical diagnoses needing to have documented goals, interventions, and timelines? So we don't expect that all medical diagnoses have interventions, measurable goals, and outcomes. We would expect that a PACE organization be able to demonstrate compliance with CMS regulations and the additional care planning guidelines released by CMS. However, we cannot discuss care plans in more detail as the discussion is often dependent on specific facts and circumstances of the given case.
So the next question we received in was back in February during the CMS audit webinar, state administering agencies were made aware of the PAC process and asked, and they thought that state administering agencies were to participate in the PAC call following the audit. So we were asked for additional clarification on whether state administering agencies are supposed to be involved in the PAC calls. And state administering agencies are not required to attend PAC meetings. They are optional attendees, and depending on their role in the audit and whether they acted as a team member for the CMS portion, we would encourage them to attend in order to provide insights on their audit experience.
All right, so the first email we had in regards to the presentation earlier, we had a comment that was made regarding feedback on in-person assessments and the need for additional guidance in this area. We didn't really have a question, but we wanted to let them know that we appreciate the comment. As we stated in our presentation, we are continuing to provide feedback regarding questions and any concerns raised by the industry to our central office SMEs or subject matter experts. This has been an area that has been highlighted for our SMEs as an area where PACE organizations would appreciate additional guidance and clarification.
We had one person ask, you stated earlier that an in-person assessment can be conducted prior to the receipt of the request by the IDT, so long as the assessment is in response to the service requested. Many requests are made during routine assessments, such as annual assessments. If a request is made for PT during a PT annual assessment, can that assessment be used as the in-person assessment in response to the service request? So what we would expect to see from an audit standpoint is documentation that the request was actually made during the assessment and documentation that the assessment actually assessed the participant for the specific requested service. And if that documentation was present, we would consider that satisfactory for purposes of audit.
All right, our next question was, can you please share the breakdown for the 33 ICARs and what universes were they in, and can you provide some examples? So we cannot list every condition that has been cited as an ICAR. However, we can say that we have cited ICARs in all of the elements except for the quality element. A condition will generally rise to the level of an ICAR if it's deemed either an access issue or relating to the care of a participant that needs to be addressed immediately. So for example, if a PO is cited for a condition for failing to provide approved care, such as not following physician orders or not providing care plan interventions, that directly impacts a participant's care, health, or safety, that would likely be classified as an ICAR. Another example would be if the PACE organization was failing to provide appeal rights when denying a service delivery request. That would also likely be deemed an ICAR, as it impacts the participant's ability to further receive the requested services and care.
We received several questions regarding how to define a service delivery request, and those questions also included several hypothetical scenarios. We cannot address individual scenarios on stage. Unfortunately, it would get much too lengthy. What we can say is that in 460-104D2, the regulation speaks that a service delivery request is made at the request of the participant or designated representative if the participant or rep believes that the participant needs to initiate, eliminate, or continue a particular service. The regulation also defines services as both items or services. We would expect a PACE organization to have a process to define and identify service delivery requests that meet the requirements in the regulation. For audit purposes, any request that the PACE organization processes as a service delivery request would then be included in the first universe.
All right. In regards to contractor staff that are in-house, is there a standard checklist that we should follow when collecting documents prior to hiring so that we are in compliance? So CMS does not have a formal checklist. Auditors use the regulations and the manual in order to highlight requirements for personnel. If a PACE organization chooses to create a checklist, the organization should review the requirements outlined in both the regulations and the manual and build it from there.
Next question, will there be clarity in definitions in the 2017 audit report? For example, definition of a service delivery request, definition of the timeline for a service delivery request, and when a service request is deemed received. We believe this question is asking if policy clarifications are going to be made in the 2017 annual audit report. Our annual report is not a vehicle for issuing policy clarification or guidance. Rather, it will be used to inform PACE organizations of the issues of noncompliance we have noted during the year. We will, however, make our central office subject matter experts aware that PACE organizations want additional clarification and guidance on these issues.
And the next question is, what are the thresholds for untimely service requests? So CMS has created thresholds that we believe are fair to PACE organizations in regard to service request timeliness. However, this is an internal threshold only, and we will not be releasing the thresholds at this time.
And the last question that we received, will the universes and templates remain the same for future reviews? So while we are constantly assessing our audit process and for process improvements, we do not anticipate changes to the current audit protocol in the near future. We will, however, publicly announce any changes that may be made.
Okay, please help me thank Caroline and Dan for taking the time to address your questions. We do, I see, have one more, so you guys can't quite escape yet.
I actually don't know if it's a question, but when I heard you say that there would be an opportunity to give CMS feedback, I wanted to make sure that you were aware of this. My name is Ursula Robinson, and I'm from the PACE program in Greensboro. And one of the issues we're running into is my team has heard that when we're in the participant advisory committee meetings, that any opportunities to improve that the participants give us in those meetings, we are to make them grievances. And so that has resulted in participants not participating in the participant advisory committee. So I just wanted to make sure that you all were aware, if not, that at least our program has had that concern.
Thank you. We appreciate that, and we'll definitely take back the guidance.
Thank you.
I'm sorry, I meant to ask this earlier. For the pain management, what are you all looking for in that field? Are you looking for any type of pain management we provided, or are you looking for higher level Schedule IIs? Or
We're looking for anything that you would actively define as pain management. So it could be a medication, but it could also be things like therapy and other sort of non-pharmaceutical interventions that you put in place to address participant pain.
Anyone else? Okay, I think you guys are good. Thank you. All right, our next session, which is session 2, emergency preparedness with Ronisha. She was unable to be here for this session, so if you do have any outstanding questions for her, please make sure that you send them into the Ask CMS Live link that is on the CTEO website, and we'll be sure to get those addressed. Our next session was coordination of benefits. Nope, I skipped one. I lied. Was financial audits. Can I ask if there's anyone in our in-house audience who has any questions on financial audits? If so, if you would like to step up to the microphone. Okay. So about we will be happy to address your question. I was looking for my speaker and I panicked there for a minute. Armando will address your question.
Armando has arrived. Yeah. Good afternoon. Again, I appreciate very much this conference. It's been very informative. 2 questions on the, or 3 questions, I'm sorry, on Part D audits. How many Part D audits does CMS do on, because there's hundreds or thousands of Part D providers. How many do you do a year?
The requirement is to audit Medicare Part D and C sponsors, so we look at more of the entities. So roughly, I have to get the breakdown, but between both of them, Part C and D, we do over 200 a year. Okay.
The other one is this external CPA firms that you contract with to do the audit, are they compensated based on the amount of money they're able to recoup?
Oh, no. They're bid out, they're firm fixed price contracts.
Okay. Also, we finished our audit and we had a corrective action plan, a couple of areas where we had to put a corrective action plan, one of which was some fees for medication administration that were not allowed. We never have an idea. Is there any idea of when somebody may come to us and say, look, you got to pay us back some money? Because we've never gotten any notice that they said, put in a corrective action plan. We did, they accepted it, but we've never been told, okay, well, you pay this money back.
I guess from CMS's standpoint, if there was an error, we would expect the PDEs to be corrected and resubmitted.
They were.
Okay, and so I guess...
This really wasn't a PDE issue.
Okay. Maybe I didn't follow. What was the exact issue then as far as...
medication administration fee. What we consider to be a medication administration fee, the auditor said, no, you can't count that way, so we have to reduce that amount that you put in your bid. In
the bid, okay. For the bids, I would think it would be a future correction then. So future bids, we would expect for that to be removed, yeah.
Very good. Thank you.
Okay, thank you.
All right, well, thank you, Armando. And we did not receive any questions from our webcast audience. Okay, for coordination of benefits for Shelley and John, are there any questions from our in-house audience? All right, so I would like to ask Shelley and John to please come up on stage.
Hi, I'm Chris Van Reenen from the National PACE Association. I also want to echo my appreciation for the material and information disseminated today. I have a quick question for Shelley about state pharmaceutical assistance programs. Are Medicaid, I am not a Part D expert, but I seem to recall from way back when that Medicaid beneficiaries didn't participate in state pharmaceutical assistance programs. Can you confirm that one way or another?
Right.
You're on.
Do you know what they do? What was it? Can do state Medicaid programs? I'm actually not sure of that, so I better check.
Okay, I'd appreciate that because I think, we talk a lot about kind of the coordination of benefits as it relates to SPAPs, and I think, there might be some confusion out here about kind of how SPAPs interact with the Medicaid beneficiary population. And I know we serve Medicare onlys, and there's a potential there, but I think it would just kind of enhance understanding.
Yeah, so one of the things is that the law did change in that it used to be that, well, now ADAPs particularly are of last resort, the payer of last resort, and they do come in after Medicaid. So with the HIV population, I'm pretty sure that they can.
On the ADAPs?
Yes.
Okay.
Yes.
And then, so then if we could, maybe just get clarification on the SPAPs.
Right.
Great.
Exactly.
Thank you very much.
Thank you.
I was just going to mention that question that we need clarification on. If you can go ahead and send that in on the Ask CMS Live survey, and then we'll have it documented, and we'll have your contact information so we can get back to you. Okay, thank you.
Hi, Kimberly Hampton from Mercy Life in Pennsylvania. I'm actually asking for one of my colleagues who is intimately familiar with Part D. But she asked if, upon receipt of the COB file, is it the expectation that the PACE organization will contact all the participants listed to confirm the information is correct? And if so, in what time period after receiving that file?
I mean, that's the one we were talking about.
So the question is, if you've got somebody on this COB file and indicates another coverage, pretty much? Mm-hmm. Yeah, so the expectation currently is that all those individuals who indicate other coverage be contacted. We are currently looking at that policy to make sure that it still makes sense, but currently, yes.
And is there a time frame in which you would expect that to be completed?
It's within 30 days.
30 days.
Yes.
Okay, great. Thank you.
Thank you.
No guarantee they'll answer.
Right, exactly.
Kim Henderson from McGregor Pace in Cleveland. I have a question about troop. So I know, troop out is easy to do for us, to send the letters, but we do ask for troop information for new enrollees, and we have yet, in the 2 years I've been there, gotten anything. So what is the regulations from us? We went through the 1/3 financial audit last year and got dinged on this, but, what are the regulations for PACE people for troop in?
Troop in from a plan that does automated troop balance, ATBT, it's really not as important, to be honest. So as long as all plans, except for PACE, have to participate in ATBT. So the answer is that if the information is coming from another PACE that does not participate, they are required to send it. If it's a plan that does participate in ATBT, that would be a non-PACE, then that information has really already been gone, into the system. So it wouldn't be required.
Okay.
And I do want to say that Chapter 14 is a little bit vague on that. I'm aware, and we are going to make a correction.
Okay, thank you.
Thank you.
Did that person send that question in electronically already? No? Oh, because that's similar. I didn't know what that was.
Okay. Yes, that is, Right. That's pretty much the same question.
Oh,
okay. Thank you.
Okay, any other questions? Okay. Well, thank you to Shelley and John. All right, our next session is prescription drug events, formulary issues, and Part D compliance. If there is anyone in-house with a question, could you please step to the microphone in the center of the room? And since there is, I would like to ask Angela, Christine, Jasmine, and Teddy to come up on stage to address the questions.
Hi, I just want to clarify a comment actually that Teddy made when you gave the example about a preferred medication list and how that might trigger indication that the organization would be considered as having a formulary. Can you clarify, is it okay to have a preferred medication list if you just say these are our preferred medications, but if you don't actually act on rejecting any requests for medications that are not on the preferred list, if that makes sense?
Yeah, that's a little gray in that area. I'm not too sure, but if you can submit the question to the Part D mailbox, I can get you maybe a better answer on that.
All right, thank you.
Good afternoon again. I'm Cliff Bauer from Florida Pace Centers down in Miami. The question I had was with respect to one of your slides mentioned a net benefit. It was slide number it was the DPSS slide. It says Part 4, and it has a net benefit. And I just wondered what did you mean by net benefit?
Yeah, let me grab my notes, and can I talk to you afterwards?
That's fine. And then a formulary question. The question you asked on the slide that we had to answer. So if we're a PACE program that uses step therapy, are you saying that we have to have submitted have an approved formulary with submitted to CMS?
Yes, any restrictions on medications are subject or deemed to be having a formulary. That's a step therapy is a restriction on the medication, and you should submit the formulary to CMS.
CMS, very good.
Correct.
Thank you.
Thank you.
Okay, any other questions? Okay, then I'd like to thank Angela, Christine, Jasmine, and Teddy for your participation today. And our last session was program agreements. If there are any questions for Denise, please step to the microphone in the center of the room. And we do have a question, so Denise, could you please join me up on stage?
Hi, Denise. I'm still Chris Van Reenen from the National PACE Association. I have a quick question in regard to the note about the 30-day waiver. So in an example, how does the 30-day waiver kind of interact with the regulatory timeframes around approvals of waiver applications or expansion applications? So for example, if you submitted an expansion application to open a new center and you have your 45-day kind of initial time frame, and then there's a request for additional information, and then you're in the second 45-day clock, are you saying that that waiver could push you beyond that second 45-day clock, which is regulatory? Or I'm just trying to understand the interaction between the two.
So this is how I'm interpreting your question. You're wondering when the 30-day clock starts to tick for the waiver, correct?
Yeah, that's an efficient way to ask the question, yes.
Okay. Okay, good, I got it. So when you receive a letter from us, you know, the approval letter, that's when the 30 days would start to tick on the waiver. Essentially, you know, you have 30 days to look at the updated agreement and say, oh, you got something wrong here, let's change it up. Most of the time, the PACE organization waives their right to do that because they want to get things going right away and they don't want to wait.
Right, no, I understand that, but there also needs to be agreement, if I'm understanding this 30-day waiver, between the state administering agency and a PACE organization. They have to jointly waive.
Well, no, it's the PACE organization's right, but we need a joint agreement that you have chosen, the PACE organization has chosen to waive it.
So the decision around the waiver of the 30 days rests with the PACE organization?
Correct.
Okay, thank you very much.
Any other questions? Okay. Well, wait. Yep. Got one.
I'm sorry. My name is Corinne Stevenson. I'm from the Center for Elders Independence in Oakland, California. And I was just wondering if when updating this agreement, have you all ever run into a circumstance since you've launched this initiative where an organization was not able to go back to the beginning of their agreement in order to update it? And if so, what are you all going to do in those instances to move forward from this point?
Are you saying that they lost the agreement? They can't find it? Or?
Well, it may not be lost. It may just be unavailable. I don't know specifically.
Misplaced? I mean, we should have a
Not
copy
available.
here, obviously, in the regions, or
Okay.
CMCS, you know. We have, in the validation process, for example, the waiver example that I shared, where we're validating past approvals of the waiver, or we're validating past amendments to any of the appendices. That's part of what we call the assessment process. So collectively, we're going to all look at our history of paperwork and ask ourselves, do we feel comfortable with what we have here? And 9 times out of 10, that's just perfectly fine. I've never run into a situation where we had no program agreement at all. And so I kind of hesitate to comment on that one. That would be a little worrisome.
Well, I guess the question is really more of a specific time frame. Do you want the program agreement to go back to the beginning of time, the initial first agreement? And if it can't go back to the beginning of time, but maybe can go back to a shorter expanse of time,
It's the most recent version that we work with.
Okay, thank you.
You're welcome.
Any other questions for Denise? Okay. Well, please help me thank Denise. All right, so we have one last session evaluation, and that is for the open Q&A session. If you would like to respond to that, please go ahead and select A, and then again follow the prompts. And while you're doing that, I just have a couple of closing remarks real quick. And the first one is, to obtain your CEU credits for today's event, please refer to page 18 in the conference guide. That'll give you the information you need to go ahead and get those credits. And then also, CMS would like to thank all of our presenters today for their time and dedication and putting this event on. And of course, we'd like to thank all of our in-house guests for participating today and our virtual webcast participants. And before I let you go, I just wanted to give you an opportunity to evaluate today's session. You guys are really quick. If you would like to evaluate today's event, that's the whole event, you can go ahead and select A at this point in time and send that response, and you'll get back a link that'll take you directly to a SurveyMonkey survey. So you can tell us what you thought about today's event and help us to improve for next events and to keep doing the good things that we are currently doing. And lastly, please remember to take all of your belongings with you. We do have trash receptacles outside of the auditorium, so anything that you need to deposit there, please do so. And one last time, thank you everyone for participating today, and have a wonderful evening.